Thanks so much, everyone, for watching. We've got an epic lineup tonight of speakers. We've got an awesome panel here. Amazing group of functional doctors, technology, activists for a leap forward in medicine.
You know, our goal is to make it easy for practitioners to learn in community.
This ecosystem that has been set up by the meetup groups, we believe will be the future ecosystem of this evolved primary care network, and it all revolves around you.
Welcome to the Functional Forum. Thanks for joining us in the charge to accelerate the evolution of medicine. Please welcome your host, James Maskell.
Hello, everyone. Welcome to the Functional Forum. Glad to have you here this evening. Super excited for one of the hottest topics in medicine. Tonight's show is called GLP-1 Agonists, friend or foe. We've already had a lot of inbound. We've had questions online for our amazing guest this evening, and I'm super excited to be coming live. We are live, so if you go to Twitter, you can use hashtag Functional Forum. I'll be monitoring it. We'll have questions towards the end, and I'm super excited to get into this topic, and I think it's ripe for a functional medicine audience. Special welcome to all the communities around the country that are watching. Just a note, I'm personally decided to take back over the Austin, Texas community because I have reason to be there 4 times this year. So this Thursday, we have the first of 4 events this year. So if you're in the Austin area, come down and check it out. We've got some great practitioners, including Dr. Linda Isaacs, who is the protege of Dr. Nick Gonzalez, and she's going to be talking about some things to do with parasympathetic tone. She's going to be talking about balancing parasympathetic, sympathetic. Very interesting work, very interesting person. We also just getting the community together. So many practitioners in Austin. It's a great community. So I'm looking forward to that. And there'll be a number of other events throughout the year. Next month, the event is we'll be going to the PLMI conference. We featured it last month. It's now sold out. It's coming up on the 19th and 20th of April. I'll be going there, and we'll be taking the cameras, and so we'll be doing a review. Typical Jeff Bland conference. It's very difficult to pin down exactly what it's about, but there's detoxification elements, there's endocrine elements, there's metabolic elements. And one of the people that is speaking at that event is with us here this evening, who is Dr. Mimi Guarneri. So Dr. Guarneri, welcome. I'm glad to have you here this evening. And also joining us for the first time, I really cannot believe it, Dr. Tyna Moore. She is a naturopathic physician and chiropractic physician, and is a 30-year veteran in our space, has been doing some amazing work online for the last 4 years, particularly, and I think I've developed a virtual kinship, maybe without you even knowing it, by all the things that we've been talking about for the last few years. And actually, maybe we could start there, Tyna, because I do follow you, and I just want to share. Actually, to start, I want to publicly share my appreciation for everything that you put out. I think you are blazing a trail in a lot of pretty interesting ways. And I wanted to actually come. This is the Functional Forum. We're talking to functional medicine doctors, and maybe to introduce the way that you think about medicine. There was a great quote that you put on social media this week that I want to ask you about. You said, if everyone who is spending loads of money on fancy functional medicine doctors and expensive supplements actually allocated their funds to prioritizing muscle, sweating, high quality protein, circadian rhythm, sun, and clean air and water, they'll be much better off in the long run. I love it. Can you explain yourself to the audience? Because I think you're right, but I would love to hear it from you.
Sure. Well, thanks for having me, James. I'm honored to be here finally. It's been a while. I'm excited, and I'm excited to talk to Dr. Mimi here. I have been chronically ill for decades myself, and I have pulled myself out of a few holes, and I have gone the route of the passive care model where I've had doctors apply treatments and apply all the supplements. And, when we're in this tight-knit community, we have access to the best of the best. And I've flown all over the country, and I've had all kinds of therapies done to me. And it really was when I finally just decided to take the bull by the horns and build this body myself. And that meant hitting the gym, getting muscle put on my body, making sure I was sweating regularly, all the things. I still take supplements, and I still have interventions that I utilize, but if I'm not putting in the work, nothing really gets done. And the last piece is sun. I live in Oregon, and I'm this week trying to buy a house in Arizona because I realized that the lack of sunlight is probably killing me slowly and painfully. So I'm in LA right now. It's great. But yeah, I just think we, as functional medicine practitioners, I'm a naturopathic physician, I'm a chiropractor, and it's, we got to get the patients to work as best we can. We give them a leg up so that they can start putting in the work. But I think it's really critical that they have to put in the work. It's not just about a pill for every ill, whether that be a pharmaceutical or a supplement.
Absolutely. And it works very well with the themes that we've had throughout the years. I mean, obviously, we've talked a lot about health coaching, right? The whole point is to activate people into participation. We've talked a lot about group visits, again, activating into participation. Because when I look at it, the biggest gap that I see is that a lot of people end up going to functional medicine doctors as sort of like a journey to understand what's going on, but then they realize, oh, I've actually got to do stuff, and then that's sort of as far as they can go. And I've really appreciated it, and I personally myself have done a similar type of thing where I do my men's group every week, and now I go to CrossFit because I recognize that I agree with you, and I think that there's a movement on muscle-centric medicine. Gabrielle Lyon, I think, coined that term, but there's certainly a movement online of more doctors talking about muscle.
Absolutely. I'm a big fan. I mean, it's like an insurance suit that you can build upon your body. So it does all kinds of good things.
Well, we'll get more into it. Dr. Guarneri, really grateful to have you here this evening, and I would say I'm really looking forward to seeing you in person in a couple of weeks in Chicago. And you've been given the mantle by Dr. Bland to sort of bring together a number of topics. I think obviously, you're a cardiologist, and so there's that. So I saw that your first talk there is really about the sort of connection between the endocrine system and cardiometabolic disease. Do you want to just sort of give us a high level as how you see that and how practitioners should be thinking about that?
Yeah, it's thank you for having me, and it's great to be with both of you, Dr. Moore, as well. I think we forget that cardiovascular disease, I know not in the functional medicine community, but in the other communities, people think it's a disease of cholesterol, right? They say, well, let's just lower the cholesterol. Of course, it's about inflammation, oxidative stress, immune dysfunction, and it's about insulin resistance and insulin sensitivity. I mean, this is what causes cardiovascular disease. And so when we start to think about what are the mechanisms, for example, of inflammation, let's just take that one. It goes way beyond, yes, there's gut adipose tissue and there's adipose cytokines, and we have to start there with adiponectin and interleukin-6 and looking at all of that. But then we go into the gut and we look at the microbiome and we say, how is the microbiome affecting cardiovascular health? How is LPS in the leaky gut or peptoglycans, affecting inflammation and ultimately insulin resistance? And then we can take a sidestep, and say, what are the other causes of inflammation? How they affect the heart? Well, it goes from the teeth to sleep apnea, to food sensitivities, and so on. So there's so many areas to cover, and I think one of the areas that I see, because this conference is about, in part about obesity and weight and lifestyle, is I see many endocrine issues like Cushing's syndrome, for example, Cushing's disease, for example, causing obesity, thyroid disease and its impact on cardiovascular health. So there's so many areas where the endocrine system and the heart come together. It's just this beautiful mosaic, if you might.
What kind of a doctor is able to, I know the answer in a certain way, but like what hope for the medical system to unravel those kind of things when the endocrinologist and the cardiologist don't really talk to each other?
Well, I think the sad part about that is, Jim, that people are given a 15-minute appointment to solve a host of complex health challenges. And I think we all recognize that that model is not working, that we need much more of community-based solutions, much more group-based solutions, where we can really transform people's health and create health. Right. So, a long time ago as a cardiologist, I recognized I had to be an endocrinologist because I realized There's no way I could treat cardiovascular disease without having to understand the endocrine system, whether it's thyroid, whether it's adrenals, whether it's, everything from, using medications that are going to affect the RAS system, that's the renin-angiotensin system. It's all connected. And so a cardiologist has to be an endocrinologist, at least to some extent, in my opinion.
Absolutely. Well, I appreciate you sharing that. And tonight we are going to get into a debate on GLP-1s. But before we do that, Tina, I'd love to get your thoughts, because what Dr. Guarneri is describing, right, is a generalist or a super generalist, right, who can understand from different parts. And I think that is at least the potential of what the naturopathic doctor was created for. And I would just love to get your thoughts on, having been one now for 3 decades. Has naturopathic medicine lived up to that potential? Is it living up to that potential? Or what are your thoughts on naturopathic doctors as the sort of generalists that we've been waiting for?
Well, I've only been in practice for 16 years, but prior to that, I was honored to be mentored by one of the greatest naturopathic doctors that I can possibly think of, Dr. Rick Marinelli, who passed away in 2013 from cancer. And he was just an absolute Jedi. He was also an acupuncturist, and he taught me about metabolic health very early on. He taught me back in the 90s about keeping your waist circumference small, strength training instead of doing chronic cardio, and really taught me the ways. And then I went to naturopathic school, and it was a different group than my mentor and his friends. And so I've sort of had the experience of like the old school NDs and then the newer school NDs. I think that the NDs, honestly, in many ways have lost their way. I think that they're trying to be primary care physicians. I think there's a big push with the schools to make them primary care physicians and get insurance inclusion. And I don't think that's what a naturopathic doctor is. I think we take care of individuals, not conditions. I was taught that I don't treat diagnostic codes. I treat people, and I'm trying to get people back to homeostasis always. And so really having that broad knowledge base is critical. However, when you are, it's like the master of none when you try to learn too many things. And so thankfully, I'm seeing certain naturopaths really focusing in on an area like maybe cardiology or pediatrics or fertility or whatnot. And I think, and mine was musculoskeletal. That's where I focus because I'm a chiropractor too. So I had that down pat. But I think that we really would benefit from bringing back some of the older ways. I was always called a renegade by my classmates, and I'm really, at the end of the day, just a traditionalist in the naturopathic world. So I don't know. I don't know where we're headed. I'm a little concerned, James, to be honest with you.
Well, I had a feeling about that, but yeah. Well, look, we won't go any more here, because whether if you're watching this and you're a naturopathic physician, send me a message with #FunctionalForum, and we'll get into that later. Let's get into the meat of it. Let's talk about these GLP-1s. This is the hottest topic in medicine. Obviously, it's going through the roof in terms of the number of prescriptions. Not even that. I mean. Clearly, Instagram and Facebook think I'm a functional medicine doctor because those are the ads that I get served. And now you can see that you could have a, countrywide telemedicine network, semaglutide network, that the structure is being built for this to be deployed, at scale to everyone at almost no cost. And I guess, Dr. Guarneri, what are your thoughts on, I know you're going to be talking about this PLMI, big picture. What do you think about this latest trend here in medicine?
Well, I have to say that on one end, I'm in awe of it. And the other end, I'm really saddened by it. I'm saddened by it because I feel like we have this powerful tool, but we don't want to forget about all the other powerful tools we have. And that seems to me what's happening here. People are looking for that quick fix, and not really getting to what we always believe, which is, what is the underlying cause? It's like having a tree that's struggling, right? We say, let's give it sunlight, micronutrients. Let's make sure the individual is sleeping, dealing with stress, all of these things that go into a human life. And we sort of whittled it down to this one little injection once a week or this pill every day. Now, I'm not against medications. I want to say that. I'm not against medication. There's a time and place for everything, and carrying 100 pounds of extra weight increases cardiovascular disease, causes decrease in cognitive decline. You have sleep apnea, orthopedic limitations. I mean, the list is endless. Cancer linked to obesity, right? So, but where do we find that balance between who really needs this, and if they do need it, how can we also augment everything else around them to transform their health? And yes, have this tool just like we have any other drug. I mean, Coreg is a powerful drug, and Tristo, powerful drugs for heart failure, right? So we use them when we need them, and we augment them with other things. And that to me is really, I don't want to throw the baby out with the bathwater, but I also at the same time, I really don't want to forget all the good stuff that we already know.
Yeah. I think last month I was sort of previewing this conversation, and I had Dr. Deanna Minich on and Dr. Jay Teeter. I asked them about their thoughts on it. And, obviously we'd all love to do the GLP-1 agonist at a functional medicine doctor's office and get all the support and surround and so forth. But like, that's not happening for most people. Most people are signing up for it on some online ad, going to some faceless telemedicine clinic, getting it. There's a race to the bottom as far as how quickly you can get it and how much you can take and how little it's going to cost. What is the likelihood of, what is the average outcome for someone who does that, who has that experience with it?
Well, personally, I think you're missing all the other pieces, right? I mean, you're missing everything else that's going on from a lifestyle standpoint. From, you just heard Tyna's quote, building muscle, getting out, exercising, being in nature, clean air, clean water, transforming the stress response. I mean, these are the fundamentals of life, community, and so on. And we're just bypassing all of that. And what also makes me very concerned is people are getting these medications. Oh, I just want to lose 10 pounds. Oh, I just want to lose 15 pounds. So I'm going to take this to jumpstart me. And then they gain weight once they stop it, and then they want to go back on medication if they're not really learning the fundamentals of health. So I take care of sick heart patients. Don't get me wrong. I want to get their diabetes controlled. I want to decrease their cardiovascular risk, but I want to balance this in a way where I'm using the medication, like I said before, like any other tool in the toolbox. I'm going to open up a Pandora's box here, Jim, because you invited me. And to me, one of the Pandora's boxes here is money, right? I think a lot of people are offering these things in their clinic and so on, and giving them to people who you would say, hey, you have to lose 10 pounds? Not a big deal. Let's get you doing X, Y, and Z. But now it's, oh, gee, for $150, I can give you this injection every week. So there's this whole financial piece that's uncomfortable as well. And I think that's part of the dialogue.
Yeah, well, it's even more uncomfortable when you find out that it only costs $5 to make and it's $150 in Europe, right? I mean, that's the old pharma games that you kind of have to buy into if you're going to participate in this as a physician. Tina, I know that rubs you up the wrong way a little bit.
Yeah, it's actually $60 a month in Germany and $150 in Canada. It's crazy. I mean, that's what I completely agree with everything you just said, Dr. Mimi. I completely agree with it. That's why when you asked me to be on this, James, I'm like, I don't know. I'm not really debating the opposite. Because
and that's totally okay too.
I totally agree, but I have actually done a lot of research on this over the past several months, and I've dove deep, and I found just some really interesting data that is really nuanced, and it's little to do with weight loss. And so I think that's why you invited me on to come have this, debate. But I really am not debating, because I completely agree. I think if you throw somebody on monotherapy at a high dose, these are hormones at the end of the day. So if you crank up the dose on any hormone as a solo unit without harmonizing the rest, and you hope for the best, these folks are going to lose a ton of muscle along with their fat. They're going to end up severely metabolically crippled at the end of the day. And I think that the way that it's being used in the allopathic community at large is a disaster waiting to happen.
Yeah, absolutely. Yeah, I was gonna, maybe this would be an interesting question for both of you, is like, if we, one of the things I think about a lot is what are the long-term health cost trajectories of someone who goes through a significant weight loss through the Tyna Moore method, right? Putting on muscle, exercising every day, eating steak and blueberries for whatever, and then versus someone who's, taking the drug for 3 months. It seems to me that you haven't changed the curve trajectory. You may have dipped it for a minute, even if you've lost a lot of weight, but that person is on a journey towards more chronic illness and more cost in the medium term, right? Mimi,
Well,
how about you? What do you think there?
Go ahead, Mimi.
No, go ahead, Tyna. Go ahead.
So these peptides actually, I've been looking at them at very low doses, and the only way to get a hold of low doses is through compounding. And the standard traditional brand name come in dispensing pens that are predetermined by dose. So you can't change the dose there. You don't really have any wiggle room. If you compound them and you add them in as adjunctive therapy into a toolkit of a comprehensive treatment plan, I'm talking fractions of the starting dose that the traditional model is using. I'm seeing incredible results, and a lot of my colleagues, after listening to me do a few podcasts on this, also started doing it, and some of them had already been doing similarly at low doses and seeing really phenomenal results. And so I look at these in a regenerative aspect. They are regenerative, they're anti-inflammatory, and they actually heal the tissues. So the long-term use of them, if done appropriately, if they're not cranked up super high, giving terrible side effects, which they can do, which, think about it though, if you had somebody cranked up on thyroid hormone or any other hormone, they'd feel awful, right? It actually heals the pancreas. It heals insulin. It makes you more insulin sensitive. It heals by decreasing visceral fat. It heals cardiac tissue. It heals kidney tissue. So the long-term impact, the way that I see them as a long-term potential, drug or peptide, is the way I would look at any other one. I'm not going off my thyroid. I'm not going off my estrogen. I'm not going off my microdoses of testosterone. And I've been utilizing them in my patient base predominantly for autoimmune conditions, cardiac conditions, PCOS. The only person I have on it, I have one person on it for weight loss. Everybody else I'm using to mitigate the immune system. They bind to mast cells. They bind to our immune system. These receptors are found throughout the entire body. They're actually, GLP-1 is also produced in the brain. So it must have an important impact there. It's neuroinflammatory. It's neuroregenerative. So I would think of it as something that you would cycle and pulse like any other hormone. And that might be for life. The way that it's being used as monotherapy for weight loss, traditionally, I think, like you said, I mean, that's not sustainable. And that's going to be a mess. It's going to be a hot mess at the end of the day.
Dr. Guarneri, what's your experience of actually, seeing patients who are on this in your clinic, and sort of from you have quite an insight with the AIHM community. What do you see through those?
Yeah, so I have a number of people who come to me who are already on GLP-1s or on tirzepatide, which, as you know, has the GIP and the GLP-1. And I started to do body compositions on them. And, I have to say, the ones that I have seen, it's not fat that they're basically losing, right? So again, I think making people metabolic cripples at the end of the game is a real and scary reality. That's first. And even though when you look at the millions of people that have gotten these drugs, even though the overall risk of side effects is not huge, right? But I've seen it. I've seen it in clinical practice. I have seen pancreatitis. I have seen a lot of constipation. I've seen heartburn. I've seen a lot of the stuff that comes along. Not terrible, nothing you can't deal with, but for some people, very real, nausea and so on. So I think that, again, I love the concept of microdosing. I love that concept, because then it becomes a piece of a bigger program, right? That it's not just about take this, lose 50 pounds, and then when you stop it, gain back, at least half of it, depending on which data you're looking at. And I think that this concept of low dose is fine, and it's probably going to be around for a long time. It's not going anywhere. But again, I've seen the light side. People happy. I lost 79 pounds. My energy's better. I'm walking. And then what I hear after that is a lot of times I'm really fatigued and I don't know why. And I'd love to hear what you have to say about this, Tyna, because I've been trying to sort through, is it because they're so low in their calories for the day, or what is really going on here? So that's another one that's not so much described, as well as emotional issues. Not as well described, but I have seen depression. I've seen it. And I saw there, we have these cases, right? So we have to pay attention.
Yeah.
Absolutely. I think those are all really valid questions and concerns. The data actually shows that GLP-1 agonists induce muscle protein synthesis. So I believe that the weight loss we're seeing, a lot of it being lean muscle mass, is on par percentage-wise with any low-calorie restricted diet.
Mm-hmm.
And when you go into a low caloric state, and I think a lot of this is dosing and management issues. I'll start with that. When a patient is dosed too high, too fast, it's going to crush their appetite. They're going to stop eating. They're going to become malnourished. Their hair is going to start falling out. They're going to be privy to potentially many of these side effects that are gastrointestinal mostly. And they're very often, and I don't know if it's the doctor not managing them well and giving them good education, or if the patient's just not being compliant. It's very difficult to get patients to strength train. I know that was something been very challenging for me to get patients to implement. So if patients are not protecting their muscle, regardless of what kind of caloric deficit is induced, whether it's via GLP-1 or via just self-starvation, they're going to lose a ton of muscle mass. And I think that's just a disaster for their metabolic health. I mean, way to shoot yourself in the foot there. That's a terrible situation to be in. So I don't think it's the peptide, because the peptide's been shown in mostly rat and mice studies, but in some human studies through various signaling pathways to induce muscle protein synthesis. So that's fascinating, but the way it's being prescribed and managed, that's not what a lot of people are seeing. I think the emotional aspect, interestingly, some big studies have shown improvement in depression and anxiety. But as you know, Mimi, you've been around a long time. When you have a patient who loses a ton of weight very fast, depression is not an uncommon side effect, right? Because let's think about our fat for a minute, just for the audience listening. Where is our hormones stored? I've seen more than one woman lose her stomach or go get liposuction in her stomach and come back just a complete train wreck because she just sucked out her little estrogen depot. Like, there went all her estrogen and progesterone. And so I think we're seeing kind of a mixed bag. And then I think for the fatigue part, malnourishment is potential if they're not eating and they're not hungry and they're not being counseled how to eat, or maybe they just, our microbiomes are programmed in childhood with what we're fed to seek out what, if you feed a kid a ton of sugar, they're going to want sugar for the rest of their life, so to speak. So I don't know if these people are even eating good quality food or making the calories that they are eating, because you only have so much room in that stomach bag at the end of the day. I don't think they're always prioritizing the appropriate food, so they're not getting the macro micronutrients they need. I think another piece is it can induce hypoglycemia. So in somebody who's prone to that, we may just be, even on small doses, I've seen that happens to me. I'm taking it for immune impacts, not weight loss, but that first day or two, I have to be careful because sudden drops in my blood sugar will happen just out of the blue while I'm driving. And I'm like, okay, I know what this is. I'm familiar with what my hypoglycemia feels like. So I think it's nuanced, and it requires a more intimate level of management from the doctor. And James, like you said, people are just getting it online and we're not seeing that intimate level. And so I'm trying to educate the public. My avenue has been to make public forward content, so folks who are on it or want to be on it or whose family members are on it can actually know what they're getting into and what it takes to actually do this successfully. But I don't say but. I have talked to many physicians and I've gone to many conferences on metabolic health. And I don't think a lot of doctors actually know what they're doing when it comes to optimizing metabolic health. They want to know, or maybe they're new to the functional medicine space, but in many cases, like I was just at a big functional medicine GLP-1 conference, and the doctor to the right of me was crushing frappuccinos all day, and the doctor to the left of me was like eating refined carbs and sleeping on his hand. And I was like, this is a disaster. Nobody looked like they just came from the gym, you know? So
And probably taking Ozempic.
we have, and a lot of them were there with no interest in metabolic health, meta-inflammation, none of it. They just, like you said, they want these cash cow practices. I'm not saying everyone, but I saw a lot of this at that conference, and I'm like, man, you're right. This is just such a money grab in many cases too. So it's nuanced, and we need more doctors walking the talk, and we need more doctors actually understanding how to treat metabolic health. Even James, even back when I was early on in practice, I was running serum insulins on patients, and my own colleagues, unsurprisingly, came down on me and were like, why are you running serum insulins? Why are you worrying about this? These people don't have diabetes. And I'm like, dude, if you get a nuanced look, everybody that walked in my clinic since 2008, I mean, probably about 85% of people had some level of metabolic dysfunction. And here we are now with 94% of US adults with cardiometabolic dysfunction. So I was just seeing it early and paying attention, you know, and getting crap from my colleagues for it. But that's the world we live in.
Well, Mimi, I know you have to run to another appointment, so I know I'm really looking forward to seeing you in Chicago, and we'll definitely shoot some more content there and get your insights. But any closing insight for us here before you head out?
Yeah, I would just want to say, I think we have a powerful tool here. I think there's going to be more of these powerful tools that come down the pipeline. And I think educating our patients and really convincing them that there's a way to do this that makes sense, right? With the strength training, with the micronutrient repletion, with making sure people are eating the right foods and so on, getting the exercise that they need, that this can be part of a bigger toolkit. And that's where I think we need to go. And I think we need to go with our eyes wide open, and everyone's an individual, and pay attention to what's going on for that individual. So thank you for the opportunity to be here, and wonderful to meet you, Dr. Moore. I look forward to connecting again.
You as well. I'm so glad to meet you.
Thanks, you.
Doctor. Take care. Thanks for being here.
Thank you.
All right. So, you know, the question I want to bring up that I was just thinking of while we were talking there is, like, I was just imagining that this drug came out in 1995, where the majority of Americans have a primary care doctor that they know and that know their family. And it didn't come out then. It came out now, where we've reached almost like peak telemedicine, right? 10 years ago, suddenly, like, you could, or, you know, 8 years ago, 10 years ago, you could get your erectile dysfunction meds without having to see a doctor, right? And so that was the beginning of it. And then you had COVID, which meant that everyone was on telemed, you know, everyone could do telemedicine across state lines. And now at this moment, 4 years after that, where it's like kind of like a free for all, as long as you got a license, you can kind of do whatever you want, this thing arrives. And it's just like interesting timing, because ultimately, you know, at this moment, it creates an opportunity for the lowest common denominator medicine, as far as I can see it, right?
Yeah, I was just speaking with Callie Means and Dr. Mark Hyman this morning on Mark's podcast, and Callie threw out some really concerning statistics about the projections of profit for these peptides, and you know how Novo Nordisk is coming in on this on the tail end, and the billions to be made. It really is concerning, and I don't know the solution. You know, I started researching this information, and I found so much compelling data showing these incredible benefits that wasn't lining up with the mainstream media, what I was seeing on social media, what I was seeing in the news, and the scare tactics I was seeing. And, you know, these peptides have been around for 20 years. It's these versions that are new that are being implemented for weight loss, and now suddenly people are losing their minds. The pancreatitis issue, for instance, the SELECT trial, which was just published for cardiovascular disease, showing a significant improvement in cardiovascular outcomes. The rates of pancreatitis were actually higher in the control group than they were in the treatment group. And some of the other big scaries we're seeing just don't have the data to support it. Like thyroid cancer, for instance, there's no causative data showing a link between these and thyroid cancer. Now, the black box warning on the peptides are for rats. They were in rats that were given excessively high doses, like to the tune of 100 times the human dose. And so I see the real concerns, and I'm not suggesting that doctors aren't seeing this in their practice, because I know doctors that have reported gastroparesis and other scaries. So you're right. I mean, without really looking at the patient, but I mean, guess who is most at risk for pancreatitis, those who lose weight rapidly, and diabetics. Those most at risk for thyroid cancer are obese and diabetic folks. Those at highest risk for gastroparesis are type 2 diabetics because their vagus nerve starts to get destroyed from the hyperglycemia. And so these patients are thrust upon, in the traditional model, high doses, slammed with them, crushes their appetite, and then they start going up sequentially in dose pretty quickly. And I don't know if the doctors prescribing this, I truly believe that none of us went $500,000 in debt because we don't care about patients. Like, I really do try to look for the best in all physicians. I just don't know how many of them are actually paying attention to the nuances that need to be managed, not even to mention, we have to support their digestion. There's data to show that their gut microbiome shifts to a more favorable biome, actually, but that shift can be really uncomfortable, and there can be Herxheimer reactions, and people with SIBO and other gastrointestinal issues or gallbladder issues can have a really hard time during that transition. And so there's just a lot here to unpack.
Yeah.
And I don't think every doctor that isn't a functional medicine doctor may be addressing these issues.
Absolutely. Well, that kind of complexity requires complex thinking, and I think that's one of the things that sets us in a good position to be valuable. How you differentiate yourself and what you're doing to the public is obviously is another kind of a conversation. I'd love to just get your thoughts on, obviously everyone is sort of cashing in on the trend, and so one of the trends that I've seen is supplements basically saying like nature's Ozempic or whatever, right? So you've got like berberine that's been put in that category, which is when I was a supplement rep 15 years ago, was antimicrobial, but now is seen as a metabolic. I think obviously it had metabolic tendencies there, but now is the nature's. I've seen it to refer to that. I've even seen probiotics that have GLP-1 in the branding. So like it's saying, hey, if you take this probiotic, you're getting the natural effect. I'm sure there are others. What are your thoughts on that sort of broad trend category generally?
This is a really great question. So we do produce GLP-1 naturally in our bodies, in our brain and in our guts. My concern, and one of the things I got to thinking about, was, what if people's guts are trashed? A lot of people's guts are trashed, right? At the end of the day, leaky gut, aging, inflammation, lack of mucin layer, lack of IgA, like it's just kind of a hot mess across. I would say most people have gut issues in our country at this point. And the toxic soup we live in, the glyphosate we eat, all of that. What if their L cells are so trashed that they can't produce GLP-1? Right? At the end of the day, what if they're not? And then I also have even found genetic mutations that are responsible for GLP-1 production. And so what if people are having like epigenetic changes that are making them GLP-1 deficient? We know that those who are obese, diabetic, and have fatty liver are GLP-1 deficient. We have data on that. So here's getting back to your question. We can take supplements that can try to signal the L cell to produce GLP-1. So we're stoking it on. But that's not the same thing as how semaglutide works, for instance. Semaglutide is almost bioidentical to our natural GLP-1. It is a peptide. It's just a sequence of amino acids in a chain. And it's got one little portion that's tweaked because natural GLP-1 has a really short half-life in the body, whereas semaglutide has a longer half-life. And so each generation of these GLP-1s got longer and longer half-lives. It used to be that you had to inject yourself every day. That wasn't good for compliance. With some of the older versions, like exenatide, I think. Moving on up, we now have this once a week injection. They're almost bioidentical. So they bind the cell, or they bind the receptor, I'm sorry, they bind these GLP-1 receptors all over the body, and they impart the action that GLP-1 would. Versus berberine or like akkermansia or some of these other stimulants, those are GLP-1 stimulants. But my argument is maybe people's L cells are so trashed that they're not going to be stimulated very well. And so I would think of them as an adjunctive to this. I would think of it as part of a comprehensive treatment plan. Like, do all the things we can naturally. Always, I was taught by my mentor, this is how I do medicine. Someone comes in on polypharmacy, we are not taking it away. We are lowering it down as much as humanly possible. I have a license to prescribe, so I can prescribe people right off of stuff. I can lower their dose, but I'm doing lifestyle medication and lifestyle interventions to try to optimize their health. And we get them on this teeter-totter where this gets down to low or no. but I don't always take people off of all their meds. Sometimes they need a little bit of something, and I'm not afraid to prescribe it. I'm not a purist that way. So I think of these like that, like how can we keep the dose as low as humanly possible, utilize lifestyle and some of these supplements you mentioned, and see if we can't get some GLP-1 production naturally happening. But at the end of the day, I do think some people would benefit, especially with this brain. That's what really got me, was like the brain inflammation, pain connection. When I realized that it was made in the brain, it stimulates POMC neurons. POMC neurons are super important for metabolic health and for well-being. And it's the same thing the sun stimulates, right? So yeah, we can do all the things, but a lot of people are doing all the things religiously, myself included. And my immune system needed a little leg up. And so I just wonder if there's not a place for these if prescribed differently.
Yeah, absolutely. Well, let me ask you, you've been on a tear here to try and encourage people to get with the lifestyle stuff. Have you learned anything from this journey from like, I would imagine just, we haven't spoken that much, but I would imagine the amount of inbound you have is dramatically higher than when we were talking pre-COVID, right?
Right.
So, through this process, have you learned anything about how to activate people into participation that you wish you would have known in your previous work?
That's a good question. Well, first I want to thank you. You were my friend through all that. And it was a really hard few years. And I took a lot of heat. And really my message at the end of the day was nothing more, dramatic than get your health in order and build resiliency so that you're not a sitting duck. And the amount of censorship that I took was shocking. And it wasn't just coming from the powers that be, it was coming from my own profession. And it was really shocking to me. Maybe people didn't like my delivery. A lot of people did. And I think I helped a lot of people. But what I have found at the end of it all, if the real risk of death wasn't enough to get people to actually take action to get their metabolic health in order, I really don't know what will.
What else have we got?
It was shocking to me the amount of pushback I got. And now that my platform's larger, the amount of people who argue for their limitations, people have real addictions. And I understand it. My entire family is obese. I get it. I come from a long line of little round people with diabetes and heart disease. And people will argue for their limitations to no end, including physicians. And this peptide does something in the brain through various mechanisms that gives people the onus of control back. And I cannot put my finger exactly on which part, because there's a couple different mechanisms without getting into all of it, but it crushes the hedonic urge. So people are less inclined to seek out crappy foods. It helps people stop drinking. It's being studied in alcohol abuse syndrome. It gets people to stop smoking. It gets people to stop with their weird little tics like chewing nails, online shopping. It has an impact on the dopaminergic pathways. But there's something happening there where folks say all the time to me, because I have so many, I get hundreds of messages now that I put these podcasts out, people coming to me saying, I feel like I'm back in control and I can make the right choices. And I wanted to make the right choices, or I was making all the right choices, but I would just sideline myself with this little thing, this little whatever it was. Maybe it was a sugar addiction or whatever. And they really feel like they have the onus of control back. And so I think there's something there that needs to be thought about by practitioners. This isn't just a peptide that slows down gastric motility and makes you not hungry. It's not that simple. It's really complicated. And I think it's doing some incredible things in the brain, particularly, that I wish we had more information on. I hope we will as time goes forward, that's giving people back some control and desire. A lot of people say to me, you preach all this stuff online. I've been trying to do all of it, or I'm doing all of it. But now that I'm on these at a low dose, I want to do it, and I'm moving more, and I'm making better food choices. I'm cooking at home. I'm doing things I was too exhausted to do before, or I had too much pain to do before. And so that to me is just testament to, like, it's not my job to judge what tools people want to use to get to their goal. I'm not here to judge and say Ozempic's bad, I'm not prescribing it, you're all just taking the easy way out. It's not that simple. People inherently don't have a weakness of character. There's something there that's holding them back. Maybe it's adverse childhood events. Maybe it's a life of abuse. Maybe it's, who knows? Maybe it's a life of eating disorder. Who knows? Yeah. I've even talked to people who had severe eating disorders who are now eating more on GLP-1s because the onus of control is back, and they're in their lap, and they're like, I actually want to eat and I'm making good choices. So I think it's up to us as functional medicine practitioners to support that process and use it as a window of opportunity to help impart changes. There's neuroplasticity happening when these folks are on GLP-1s. It's actually regenerating neurons. So my take is let's use that window of opportunity while they're rewiring their brain to rewire it for good habits.
Yeah.
And take it, use it as a learning opportunity for them.
So if you were designing a GLP-1 program for a functional medicine clinic, and obviously you have for your own, what are some critical pieces as far as like what to educate when, how to support when, so that you take that small window of opportunity and turn it into lifelong habits?
I'm noticing, and I've talked to many practitioners using these, what we're all in agreement on, and maybe the audience has some insight on this as well. It seems to be around month 2.5 to month 3 that all the lights come on. So the weight starts coming off. And I have noticed too, so I'm using it more in metabolically healthy folks than not. The majority of people I have on it are already kind of doing most of all the things, maybe not all the things, but close to it. And so the sun's going down where I'm at. Sorry, I'm in a shadow.
Okay.
I'm at a hotel in LA. Anyway, they are noting that they're losing just a bit of weight, kind of getting back to their fighting weight. So I dropped back down to my 2019 weight, which was the weight that you'd always known me at. But over the course of the past few years, because of stress, my metabolism was getting busted and I gained some pounds during that process. So I'm just back to my normal weight. And that's what most people report. So I don't take things away from them. I wait for that onus of control to kick on. And so I want to encourage, and I've always been this way, I want to encourage patients to add healthy habits versus subtracting. Now, if they're severely diabetic, I'm going to give them the sugar is evil talk. I give everyone that talk, but that doesn't mean I'm going to get somebody off sugar right away. I'd rather they prioritize protein. If they're getting enough protein macros, they're not going to want to eat as much junk. So that right there starts to push out some of the refined carbohydrates. If they want to go extreme and do a little bit more of like a Atkins induction or like that carnivore type thing, fine, we can do more meat-based. But I want people to really just start focusing on hitting goals and getting little wins stacked. I want them to start walking. Usually around month 2 to 3, they start asking me about strength training. They start feeling more ready for it. I would make sure that we're addressing thyroid and adrenal gland function like right off the bat. So but basically I'm just doing all the same stuff I always did. Just have GLP-1s in there. So I always support adrenal and thyroid first. Then we have a deeper look at the other sex hormones and gut function. Kind of depends on what they're coming in with as to how fast I get to what. But all of it, all the things, all the same things I would always do, I address. I know that most practitioners have their favorite GI testing. I just want to make sure that we're not taking somebody with a compromised GI and, hitting them too hard. And then I'm very careful with the dosing. The second I hear nausea it's funny, patients won't put 2 and 2 together. They'll say, I woke up yesterday, I threw up. I don't know why. I'm like, because you're on a GLP-1, let's lower the dose. So I back them off to where there's no symptoms, or maybe just the tiniest bit of mild nausea, which tends to go away. And then we just keep them there. Or maybe we up them a little bit depending on their goals, but I'm using it for, like I said, all kinds of different conditions that have nothing to do with weight loss. So my goals are like, is your psoriasis going away? Is your acne clearing? How's your depression? How's your mindset? I've got one patient on it who's a neurodivergent young woman, and she was about to lose her job because she just couldn't, her ADHD was so severe. Now she's clear-headed. And I notice when she stops taking her dose because she gets a little more confused and she starts missing things. So I think we have to meet the patient where they're at and apply the treatment hierarchy according to what that patient needs. But of course, addressing all the basics, it can make sleep better. It can make sleep worse. It can give people lots of energy. It can induce maybe a little bit more fatigue. So that's where we have to look at the patient, not necessarily the peptide, and be like, okay, what's going on here? How can I tinker with this piece and, optimize their health? And then some people just can't tolerate it. And that's the reality of that situation too.
Cool. Yeah, look, I really appreciate your insight on that. And I think that's really helpful for practitioners. One of the interesting things about this journey is me, I guess, trying to think about, like, it was interesting to me to think about, based on what I knew about certain practitioners, would they be for it or against it based on how I saw them acting in the world previously. And anytime there was an anomaly there, you were one of them, where it was like an anomaly, where it was like, how is she into this? Like, what I understand about this is all your muscle goes away. She should be really against it. And so that she's triggered me to try and learn more about it, because I saw things that I wasn't expecting, in the community. Let me ask you, we did have a question coming in. So this is from Lynn Cutler, PhD, RN. She's a health coach. She says, I've done a brief literary review on semaglutide in relation to several cancers. My question, can the same be said for allulose as GLP-1 agonists? Does that make sense to you?
Not quite.
Okay.
As far as the cancer goes, there are correlative studies that were honestly kind of half-assed. They basically took like health record data going over a period of time, and then correlatively was like this group that was on GLP-1s had more of this condition, or this, maybe it was pancreatitis, maybe it was cancer. The whole group as a whole were type 2 diabetics generally. So the conditions that they were looking at are more common in that population as is. And we don't know how many years they've been diabetic. We don't know how diabetic they were. We don't know what their dose of semaglutide was. It can cause some hypertrophy in certain cells in the pancreas because it suppresses glucagon. So I'm cautious and I'm very careful with the patients I talk to. But again, I wonder if that isn't from this high dose monotherapy too. Like, if you start cranking testosterone, you're of the age group where maybe a little bit of testosterone might be helpful to you, or it might be in the near future. But if you're cranking testosterone, that's no good. That's not something we love. So I don't know about the allulose though. I'm not sure what her question is on that. Maybe clarity.
We'll come back to that as we move along. All right, another question here is, when you say microdose, what kind of dosage are you talking with patients?
It depends.
Okay.
So it's completely different for every single patient. And that's why you have to work closely with them and figure out what's going to work best for them. So I always start super, super low, and I get it compounded so I can do so. And I go up to tolerance. And then we see what happens. We wait. I do think this peptide takes some time to kick in. It's just like any other hormone. It's going to take a minute for us to see. So with any hormone that I prescribe, I monitor closely for 90 days to see what's happening. And, at 90 days, we make a decision on what that dose is going to look like for the long term. So it really depends on the patient, and then I cycle it. And the cycling is different for every patient. It might be like with most hormones, I do a hormone holiday. I do 1 week off, 3 weeks on. Depends on the patient though. Some people can't take a week off without their symptoms returning. So we might do one, with some testosterone. With some young gentlemen, I'll do 1 month on, 3 months, or I'm sorry, 3 months on, 1 month off. Might do that with GLP-1s too. So it's kind of all over the board. And it really comes down to, I think, having a base knowledge of bioidentical hormone replacement therapy treatment is really helpful, because I did that for a long, long time. So to me, this was just like, oh, let me just add this to my tool bag. And I think for a lot of doctors, I know in the naturopathic community, it's not as well known on how to do hormones. So that's a good training.
I guess you also did a lot of peptides, right? That was part of, you had a regenerative practice for a number of years.
Well, I was closing up shop on my big practice. I still see some patients, but I was closing up my big practice right about the time that peptides got big. But I use them personally for sure. And I use them with my family. And I've got a lot of people in my family. So we got a lot of peptides going around. It's just, peptides in general are pleomorphic in the body, and they are regenerative, and they heal what they need to heal. And so that's how I look at GLP-1. Is what is the dose? And I will tell you, there's no standard dosing. I wish there were. I wish there was like this cookie cutter algorithm for peptides as well, but there's just not, because let's talk about BPC 157, something that's regenerative, helpful, deemed very safe. Lots of people have used it lots of different ways, had really great impacts. If I take too much of it, I swell up. I get super bloated super fast. The same thing happens to me on creatine. So to each his own. This is individualized medicine. So I would say if you are a physician and you're wanting to microdose these, just start super tiny, start slow and low, and then just bring them into your comprehensive treatment plan as you normally would any other hormone, and keep a sharp eye on the patient and make sure they're giving you feedback. And it's really painless. It's not scary. People are doing really well. People are having all kinds. I've got one colleague using it. She's a mold specialist. She's using it with SIRS, mold, Lyme, people who just, their blood sugars are all over the place, or maybe they've got, they just can't get on top of the chronic illness picture because of whatever's happening there. And a little bit of GLP-1 cleans up the clinical picture for them. And the outcomes have been really cool.
Yeah, I mean, it sounds like you need to have a good relationship with your compounding pharmacist too, because that's going to be the trick to get those. Any concerns on that? I mean, I always wonder what is the fallout of the relationship between doctors and pharmacists post ivermectin, or those kind of things. Like, was there issues in relationship capital through the pandemic that still remains? I don't have any idea on that, but I wonder if there is.
I'm sure. I've heard from some doctors who had their prescriptions refused, and they're pissed. So I just think I part of my privileged bubble is that I had always known about compounding pharmacies because I spent decades with Rick Marinelli. So I just had always thought that all doctors knew about compounding pharmacists. And so when I started talking about these, I mean, it was really naive of me. And when I started talking about these GLP-1 agonists from a compounded version, I quickly learned from my followers that most people have no idea what that is. And then the FDA has done a very strong job of smearing these peptides, the compounded version. I don't know what's going on there specifically, but all of the compounding pharmacists I've talked to. So I interviewed like as many clinicians using this, as many compounding pharmacists as I could. I mean, I was incessant and I was probably annoying to a few. I was like, hi, I don't know you. Will you do a Zoom call with me? Because I need to talk to you about this. And all of them reported the same thing. In most cases, they found that most doctors had no idea what they were doing with them, that keeping the dose low is actually very effective and very, very safe. And no one's having any problems with the compounded version. Compounding pharmacies don't want to get in trouble. They're not hawking counterfeit goods, black market, whatever. Those articles that you see start out with, compounding pharmacies bad, and then they go into some like terrible story about people buying the stuff online randomly and from who knows where. And then at the end, they're like, well, the compounding pharmacies don't really have any issues. But I do think there are folks getting into trouble with dosing themselves at home, patients, or maybe because you have to pull up the amount you want out of the syringe or out of the vial with a syringe, whereas the brand name version is a pre-filled dispensing pen. So I think people might be messing up and pulling up because some of these can be quite concentrated and it's a little iffy. Like, if you're only trying to get 5 units and you accidentally get 7, you really could have some gastrointestinal side effects from that. So, we just got to be careful. That again, though, comes down to good education from the doctor. I never send out somebody with a needle and syringe unless they have an in-office training. And we make sure they know what they're doing,
Absolutely. Tina, thanks so much for doing this. I really appreciate it. I think everyone in the community will appreciate it. Over the last year, we've had a little bit of, conversation on this because it's just coming up so often. It seems to me that you may need to have past history with GLP-1s on your, health history, right? Because of the potential metabolic effects of doing it wrong and what that would lead to. So that, it seems like, this is another question for the health history to really understand where people have been, especially, over the next 10 years where you see, people are going to have all kinds of interactions with it, all different deliveries of it. And it just seems to me that, this is a moment where, again, like our community could shine if organized in the right way because of the complexity of the situation, because of the interdependence of the systems. You're in a good position to be of most value. And then it's just a question of being of value and doing it and communicating the message well to the people out there so that they know there's a different way to do it, taking advantage of the drive towards health. And like, you bring up a really good point. If there is some process that's happening where through taking this medication, the locus of control is returning to them, I think that's very interesting because I think, so much of medicine is the opposite happening. And I think we saw that so much in COVID and now we need it to swing in the other direction. So I'm really grateful you brought that up because it's revitalized my mind on it. We will be next month. We will be back with, we're actually going to go to the PLMI conference. There's some amazing speakers there. We've had some of them on last month. Dr. Mimi Guarneri will be there and many other doctors. And, it was a year ago actually when we had an event and I found out that this was probably going to be the topic for next year. And so I've been keeping a special eye on it, but we're glad to, to have more diverse opinions and I'm excited for more. So if you're watching this, I highly recommend you follow Dr. Tyna, DRTYNA, on Instagram. It's been a wealth of information for me over the last few years, and I've really enjoyed our back and forth online, and I'm excited for the future. And everyone, thanks so much for watching the Functional Forum. We'll be back first Monday of every month, whether you're watching this at home or whether you're in your communities. And if I'm going to see you